time. And since we only have an hour, I will get us started. My name's Fiona Miller. I'm a professor of health policy here at the University of Toronto and director of the Collaborative Centre for Climate Health and Sustainable Care. And before I introduce our speaker, I would like to just take a moment to acknowledge where we are and to do a land acknowledgement. This is a beautiful image from nativeland.ca, where you can look across the Turtle Island and see the different languages and cultures and nations. We are here on the North Shore of Lake Ontario, and here at the University of Toronto, these are the lands that for thousands of years have been the traditional territories of the Wendat Nation, the Mississaugas of the Credit, and the Seneca. And today, of course, the city of Toronto is a thriving home to many, many different Indigenous peoples from across Turtle Island. And the teachings of our Indigenous colleagues, of scholars and elders, are really quite central to the questions of sustainability, of living on and with all our relations, living with in peaceful relations with the land, in productive relations. So it's very important to us to acknowledge these relationships and knowledge systems. So I also want to just briefly introduce the Collaborative Centre for Climate Health and Sustainable Care, which is an initiative of 4 health science faculties at the University of Toronto. We've just turned 2.5, so if you're interested in reading our 2.5-year report, and there are many ways to become engaged in our work. We have our major annual conference coming up in October. We'll be announcing the full agenda over the summer. So we'd love to stay connected with you as we have these kinds of opportunities to meet with and learn from scholars all over the world. And so today I'm particularly delighted to welcome Professor Dr. Hatice Camgoz Akdag, who is a professor of management engineering from the Istanbul Technical University and is here visiting with us in Toronto. Her PhD is from Brunel University with undergraduate and master's in management. So it's this combination of process engineering as well as management science, which has tremendous relevance to these questions of how we drive improvement in healthcare from a sustainability perspective and with sustainability objectives in mind. So with that, I'm going to turn it over to Dr. Akdag to introduce us or present her talk. Thank you.
Thank you very much, Professor Miller, for the kind invitation and also the information that you have given. So thank you for joining me today. My apologies to the face-to-face audience because I have to look at the camera here. So
can you present?
I will.
Okay, sorry.
Yeah. Oh, sorry for that. Just a second. Oops.
Perfect.
Slides, presenter view. I would like to see the presenter view, but I did it a moment ago. Okay, now Okay, so thank you for joining me today. My name is Professor Hatice Camgoz Akdag from Department of Management Engineering, Istanbul Technical University from Turkey. I'm incredibly honored to be speaking here as part of our of the Collaborative Centre for Climate Health and Sustainable Care, University of Toronto. Thank you for Professor Fiona Miller for inviting me. So today we'll be exploring a vital cross-section of industries. How do we take the operational rigor of industrial and management engineering, specifically lean methodologies, and apply them directly to the climate crisis within healthcare delivery? And over the next 30-40 minutes, we will look at how operational inefficiencies in hospitals directly translate into environmental burdens and how we can systematically redesign clinical pathways to be patient-centered, lean, and climate resilient. Well, let's ground our discussion in the data. As you can see from the slide that if the global healthcare sector was a country, it would be the 5th largest carbon emitter on the planet, accounting for approximately 5% of global greenhouse gas emissions. It's a profound irony that the sector dedicated to human healing is actively contributing to the environmental degradation that causes chronic illnesses. Second, studies show that up to 80% of waste in certain hospital operations is entirely avoidable. And this isn't just physical trash that we think of. It's wasted energy, redundant clinical steps, and idle machinery. So the core thesis of my research is that healthcare sustainability must transition from a superficial recycling initiative to a core strategic operational transformation model. To solve this complex problem, my research program sits at the intersection of three pillars: lean healthcare, sustainability, and management engineering. For those who don't know, the difference between management engineering and industrial engineering is that we in management engineering department, we have 2 years of core engineering classes, and the next 2 years we teach them the managerial courses like finance, economics, HR, marketing, which also gives them the chance to have a management perspective. So they are not only related to improve the factory of the production, but they can form a company, run it, and produce and sell at the end. So what we do is with this management engineering perspective, I also added it to the healthcare improvements issue. The first pillar is lean healthcare. This involves tools like value stream mapping, which I use a lot, and material flow, for example, actively hunting down bottlenecks to maximize value delivery to the patient. The second perspective is sustainability, which demands circular systems, thinking, carbon footprint reduction, and resource efficiency. And the third, binding them together, is management engineering perspective. This provides us with data-driven decision-making models, process redesign methodologies, and statistical tools to ensure that modifications to a system are permanent, measurable, and scalable. So the foundation of our scalable framework relies on cross-research foundation, cross-referencing traditional operational metrics with ecological indicators at the same time. So historically, a hospital measures patient throughput and waiting times to judge success. Our framework expands this view. We couple patient waiting times directly with energy and water consumption, medical waste generation, and workforce strain. For example, if a patient is waiting 3 hours in an emergency department, the building is still consuming electricity, heating, and water to sustain that waiting space. Therefore, optimizing throughput is directly linked to reducing a building's ambient carbon footprint. But it's more complicated than that, though. This framework did not appear overnight. It's been 20 years that I'm dealing with quality in healthcare, patient pathways, starting from just visit to the physician until the diagnosis, and afterwards the treatment and cure. So it represents a multi-year evolution in our academic approach. We began years ago focusing heavily on lean efficiency, which is classic waste elimination, standardizing work, and cleaning up chaotic pathways. As our research deepened, we moved into systems redesign, looking at broader quality management systems and aligning clinical guidelines with administrative flows. So it's not only a quality perspective, it's not only a clinician's perspective. We joined them together. And today, our mature research program integrates climate resilience. We're taking those optimized flows and asking, how do they hold up under climate shock? How do we build circular supply loops with hospitals to completely decouple healthcare growth from environmental degradation? For example, let's look at a concrete case study within a highly resource-intensive environment, the radiology department. I have done a number of researches, case studies, value stream mapping, and improvements in radiology departments in my country. And a radiology department is a heavy imaging equipment, has heavy imaging equipments like MRIs and CT scanners, as you all know, and are notorious energy sinks. So they also represent massive capital investment, where scheduling delays cause enormous patient anxiety. Some of them, the patients are lost. We lose them. They just quit coming, and even if they have cancer, they will not be diagnosed, and it will have even more severe results at the end. So when we applied lean design to radiology workflows, we mapped out every single step from the moment a physician orders an image to the final diagnostic report. So we discovered massive coordination gaps, such as patients arriving unprepared, missing paperwork, or transport delays, so which left multi-million-dollar energy-hungry machines sitting completely idle between scans. By reorganizing the scheduling, the pre-arrival patient communication, and technician workflow, we achieve substantial sustainability outcomes. So mechanically, we drastically reduce the energy consumed during idle states. By batching procedures and streamlining transitions, machines spent more time in active, productive use and less time wasting baseline power. So materially optimizing workflows reduced procedure repetitions caused by positioning errors or incomplete scans or rescanning. And this saved clinical consumables and lowered chemical waste. So the ultimate outcome is a direct drop in the carbon footprint of every single diagnostic image produced. This is another interesting case which I have been dealing the last 15 years, though. I have a group of specialists who are breast cancer surgeons, oncologists, radiologists, pathologists, clinicians, nurses, which are all dealing breast cancer. Sustainability is not just about turning off lights, though. It's deeply rooted in human equity and clinical excellence. This is how I found myself in sustainability, though. I checked that the SDG 3, good health and well-being, and because we were always trying to standardize the cure of cancer in our country, the diagnosis standards, etc. It wasn't standardized. The surgery was not standardized, so everybody was trying to handle it. If you were in a big city in Turkey, yes, everything would go well. But if you were in a suburb, then everything won't go the same way it would. So I thought that everybody should have the same standard of all this path. So nowhere is this more apparent that in our work on breast cancer clinical pathways, working with International EUSOMA, the European Society of Breast Cancer Specialists, we designed a workflow aimed at completely eliminating diagnostic. And I was also the auditor of the first breast cancer center in Turkey, Istanbul. And for a patient facing a potential cancer diagnosis, every day of delay is an agonizing psychological burden. By creating an integrated human-centered pathway, we bring the specialties, the imaging, and the biopsy capabilities together around the patient so that we minimize the travel, we minimize the repeat visits and the systematic delays. There's another research that figured out that a woman to get diagnosed with breast cancer has to undress 9 times in our country, and we dropped this to 2 with all this reorganization. And it did work. Even the diagnosis time has dropped from 15 days to 2-3 days. So it was easier for us to capture. And then I found myself to be diagnosed of breast cancer while I was researching on this topic in 2017. And then it was a great chance. That's what I see. I'm cured totally, thank God. But I had the chance to see how things were going on really in the patient's perspective, that there were lots of bottlenecks, lots of mistakes done. Someone had to get the chemotherapy in 14 days, but because everybody was taking it 21 days, every 21 days, they misorganized the patient's cure to a wrong date. And if the patient knew what was going on, they would interrupt. But if not, then all the cure was going to be upside down, etc., and the outcomes will be really dramatic. So it was a really great project for me as well to be joined and to be able to make it applied in the country. To scale these interventions, we deploy 4 distinct operational tactics in outpatient clinics. The first one is value stream mapping, which I really like. The first thing I do is I draw the current state map of the flow, which allows us to visually draw the patient's entire journey so that cross-functional teams can see exactly where delays happen. At the moment, we draw it on a simulation software, and we also set alternative scenarios with different constraints. And at the end, we optimize the best scenario and apply that one. So it's easier to play with it in a computer program instead of trying and failing on the real site. So the second, waste analysis explicitly targets administrative redundancies, such as patients filling out the same medical history multiple times. Third is capacity balancing, which uses mathematical modeling to match staff schedules with historic patient arrival curves. I'm also a professor of production and operations management, so we do all these modelings, mathematical modelings to the scheduling of the staff, as well as with the machine or even the OR rooms, etc. And finally, we minimize physical movement waste, re-architecting the physical layout. So we also do layout design in production and operations management of the clinics so that nurses and physicians, for example, walk less time or spend less time walking down long corridors to retrieve the supplies and more time at the bedside. So everything we talk about requires a robust foundation of high quality data. In the management engineering world, we say if you cannot measure it, you cannot improve it. So integrating clinical data registries is an environmental imperative. When data systems are siloed, doctors in the emergency room cannot see the labs run by a primary clinic 2 days prior. I'm not only talking about this country. Maybe you have this system, but we didn't have it 10 years ago or 5 years ago. They put them all together so now the doctors can see it. But before that, we were reordering the blood tests, we were rerunning the x-rays, which created a massive material waste in labs, excessive plastic use or chemical processing waste, and unnecessary financial costs though. Well, when you have the data and the data is organized and cleaned, then we can implement the decision support models using multi-criteria decision-making methodologies, which we call MCDM, which allows clinical teams to evaluate treatment protocols, not just on clinical efficacy, but simultaneously against resource constraints, patient preferences, and carbon impacts. We also did one MCDM model on the surgery of the breast cancer, for example, for a woman. We're looking at the clinical efficacy, we're looking at the cost, we're also adding the patient's preferences, the type of the cancer. We have hundreds of different issues that we have to face. So this multi-criteria decision-making model is helping us to make the final decision, which everybody would be happy to, including the climate. So these models ensure optimal resource allocation, matching the complexity of patients' condition with the exact level of intervention required. So this prevents the systemic overconsumption of resources and drives clinical consistency across different teams. When we look at this physical composition of the healthcare waste, as you can see from this distribution chart, medical and hazardous waste accounts for roughly 40%, followed closely by pharmaceutical waste at 30%. General recyclables make 15%, and operational time and flow waste represent another 15%. So what's critical to understand here is that these categories are interconnected, so they're not separate from each other. So when process flow is poor, pharmaceutical expiration rates increase because items sit in inventory too long. And when stuff are rushed due to poor scheduling, they default to throwing, for example, general waste into hazardous waste bins because they don't have time to segregate, or inflating hazardous waste processing costs and environmental damage by up to tenfold. We must also recognize that this is a two-way street. So it's not only looking at the patient pathway or the healthcare efficacy. So while healthcare impacts the climate change is putting unprecedented stress back onto our healthcare delivery systems. We are seeing acute spikes in admissions due to heat waves, vector-borne diseases, and severe weather events. So at the same time, supply chains are becoming fragile, causing frequent shortages of critical medications and medical devices. So an inefficient hospital system operating at 98% capacity buffer will collapse under a climate-induced patient surge. So building lean pathways creates the operational resilience required to absorb these shocks. To synthesize these findings, I'm presenting this proposed integrated framework. It unites 4 distinct operational realms into a single hospital strategy. The first one is lean optimization. So it provides the foundation of a value stream mapping and flow optimization. Secondly, environmental management layers and energy efficiency, waste segregation, and circular procurement. The third is digital care leverages the electronic registries and decision support algorithms we discussed. And finally, resilience engineering ensures that our optimized processes are flexible enough to handle extreme environmental and public health disruptions. We had faced the COVID-19 and the whole world was struggling with all these closure in the supply chain loops, medications, etc. So we did face that. So now we know what can happen in the future, and we have to be resilient for that as well. This one, I drew it from Google Gemini. Actually, it's a butterfly effect diagram of circular economy. The left-hand side is the biological cycle, and the right-hand side is the digital cycle. It's showing you how the biological cycle can continue in healthcare with the lean optimization, waste elimination, and environmental stewardship and regeneration. I will share this probably on LinkedIn so that you can also have it. And on the right-hand side, we have the digital cycle. So that, as you can see, we are using IoT, cloud, generative artificial intelligence, together with real-time data, remote monitoring, predictive analytics, and AI-assisted decisions. I know a lot of radiologists in my country, which is using AI and machine learning for diagnosis at the moment. They're comparing like 2 different machine learning programs together with his own bare eye, and he's comparing their success at the end. Resilience, and it's also minimizing the amount of time they spent bare eyes, and also the biased results, which sometimes they can say that it's cancer, but it's not, etc. Resilience and adaptability is that system flexibility, preparedness to shocks, cross-functional teams, strategic redundancy. And at the end, we have to have an integrated orchestration. So they have to work together. None of them are working alone. So how do we execute this framework? It requires 3 key strategic enablers, the organizational enablers, which demand that leadership move past short-term financial quarterly reporting and commit to long-term ESG, environmental, social, and governance metrics. So we have to integrate both of them. Technical enablers require investment in modern digital infrastructure for real-time data visibility and smart process analytics. But most importantly, the human enablers requires engaging our frontline healthcare workforce. Physicians and nurses are exhausted already, so we cannot frame sustainability as an extra core. We must show them that lean sustainable pathways actually make their daily work environments less chaotic and more rewarding. We must be realistic, though, about the obstacles. So this matrix outlines the primary barriers we encounter across our international research projects. Structurally, healthcare systems are deeply fragmented. and regulatory complexities make rapid process iteration difficult. On the other hand, operationally, there's always natural institutional resistance to change. People don't like change, and exacerbated by severe workforce overload and the lack of clean, integrated data. From the sustainability perspective, a pervasive short-term budgeting vision makes leaders reluctant to invest capital today to save carbon and operating costs tomorrow. Acknowledging these barriers allows us to design a deliberate mitigation strategies. So as we begin to wrap up, I want to leave you with a core philosophical takeaway from a systems engineering perspective. Small operational inefficiencies accumulate into large environmental burdens and workforce stress. So when a single doctor's clinic runs 15 minutes late, it ripples across the facility. It causes transport cars to idle, patients to drive to rescheduled appointments, extra lights to stay on, and staff to work overtime. So we cannot achieve macro sustainability targets without fixing these micro operational steps. So transformation requires end-to-end process thinking. Well, our research that I'm covering with my PhD students, master students, even with my undergrad students, our research models are explicitly designed to align with broader global frameworks. When we optimize an outpatient clinic or a radiology department, we are directly contributing to the World Health Organization's sustainability guidelines and the United Nations Sustainable Development Goals, specifically the SDG 3, for example, good health and well-being, or SDG 12, responsible consumption and production, and SDG 13, climate action. We can even add more. These are the direct impacts, though. And our model shows that by targeting 95% threshold in patient outcomes, we can simultaneously achieve an 80% improvement in operational waste minimization and align perfectly with regional carbon neutrality pathways. Sorry. Where is our research heading next? So the future research directions, we are developing 3 core frontiers. We are integrating AI support into operational models using machine learning to predict patient arrivals and automatically adjust the heat, ventilation, air conditioning, and equipment scheduling to minimize baseline energy pull. Second, we are expanding our models into circular systems, which at the moment, the conference of partnership, COP31, will be held in Turkey this fall. And the major title is circular economy. So we have to also apply to healthcare, which is analyzing medical device supply chains to facilitate safe reprocessing and reuse. Finally, we are building real-time digital KPI dashboards that display a clinic's live carbon footprint alongside its waiting times, giving managers immediate visibility into their environmental impact, so you can see what will be the cause afterwards. And this is, again, something that I made Google Gemini to draw for me, including the 3 pillars: AI, data intelligence, circular medical systems and resource recovery, digital performance measurement and recovery. So you can see that everyone is interrelated with each other, and it's a cycle. So it's a never-ending process of improvement as well. Same thing. So as we look to the future, the conclusion is clear. Developing lean, sustainable, and patient-centered healthcare systems is no longer an option or an optional luxury or a niche academic interest anymore, which most of the clinicians thought we were doing that 20 years ago. It's an absolute necessity for building climate-resilient societies. We have the data, we have the engineering methodologies, and we have the clinical standards. So what we need now is the institutional will to scale these models across our global healthcare infrastructure. So sustainability must become the very foundation upon which future healthcare is built. And with that, I want to thank you all so much for your time, your attention, and your shared commitment to a sustainable future. I would also like to thank once again Dr. Fiona Miller, the Director of Collaborative Center for Climate Health and Sustainable Care, and all the colleagues which are also helping me here for organizing this critical dialogue. I'm very happy to open the floor to any questions, comments, or potential research collaborations you may wish to discuss, and thank you very much.
Wonderful. Do you want to mute there?
Shall I mute it here?
Yeah. Turn on this. Wonderful. Thank you very much for that talk. Please, I'll be taking questions in the room and online, but I'm going to take the privilege of the chair, and I have some questions. I have quite a few questions, actually, so others better start getting ready or else I'll monopolize this conversation. So I wanted to ask first, the classic question really about AI, right? Which is that AI is obviously an enabler of efficiencies and improvements, but it's also itself a huge environmental impact unto itself. And I think beyond the immediate, it also poses the risks of doing more, of encouraging sort of the digitalization question. So it's not just digitizing what we already do, but it's potentially encouraging us to seek more data, do more. So is that an issue here? Is it something that is a balancing measure that you're considering in any way as you mobilize AI to support these improvements?
That's a very good question. Thank you very much. What we're really doing is that, yes, we are balancing it because there are pros and cons of every single methodology or digitalization. We have to make sure that using AI will give us a less climate burden at the end. So we do add those constraints also into it, and we try to optimize the solution at the end. But yeah, at the moment, AI is capturing better with the diagnosis, for sure. So we are reaching almost 98% of true diagnosis, which is helping us secure the patients better and faster. Because if we miss that, then in reality, we would be given biased medication or no medication, and we wouldn't cure the person, and it would cause severe results. Well, when you think about it as producing a product, it's easier. You just put it into reproduction, or it becomes defect, and you throw it to the garbage. But you cannot do that for a human being. So it's more important to check the balance and
right. I'm not going to go on about. I could start talking about the limitations of early diagnosis, but I won't. I have another question for you. Because one of the things that I find so interesting about your approach is that you've got resilience in there. And I think what we see more and more of is, mobilizing quality improvement or process improvement for sustainability. But the other side of this, which is adaptation to risks and resilience, I haven't seen it as commonly integrated. And I think you were characterizing this as the third step in a process. But I guess my question is around whether there are tensions there, because when we think about resilient systems, and I think you mentioned that, strategic redundance, we're looking for, self-organizing systems, a certain amount of redundancy is part of resilience, which inherently is a bit in conflict with efficiency in any event as a pathway to sustainability. So I'm wondering if that is in fact something that you've seen, if it arises in your model, if that's something you have to...
Yeah. As I mentioned, specifically after the COVID-19, we realized that we should have robustness and resilience so that we will not be affected with all those things happening outside our environment. So we know that the climate is changing, and we know what's going on and what can be the effects at the end. So we have to also make sure that our system will continue to work with all those changes, and it won't affect our healthcare system.
But you didn't find tensions between?
Not yet. No, not yet.
So I'm sure there are questions that are starting to percolate out.
Yeah.
There you go. Okay.
I have another question.
Yeah.
So I'm a health policy professor, so this will be obvious why this question is coming, perhaps. So you're talking about, I think, a focus on process improvement and sustainability that focuses on a unit or a hospital as a whole. If that's true, and I guess the question would be about applying these methods to a system. So it's also referral pathways and different care options in the home or in the hospital or anticipatory work. So the wide question of system impact, which I think is an even bigger piece to try and to get a hold of.
What we're doing is that we are trying to reshape the whole system of the country. So it's not only at hospital or a clinic. So what we're trying to do is we are trying to merge every single sub pathway or process and make it one single system. But the first thing in Lean or Kaizen that we're doing is we have to put it into sub systems, simple systems, make it lean, and then put them together to get rid of the complexity. But what we really want is that we want one doctor to be able to see, for example, the patient's records in a totally different city, for example, or the bigger dream is that the whole world will be on the same system, which is impossible.
Right.
Because for example, we have rare diseases, right? And we cannot have a hub everywhere in each country when you have just a rare disease of 50 people in one country. So you have to put them together to be cured in a country. But and the medication is very expensive. So I did a research on that as well with rare diseases, because it's too expensive and it's hard to diagnose, and we need a hub. So, for example, Turkey can be a hub for Asia, etc. And for including climate action or sustainability into it, yes, my dream is to have it as a whole system, but at least trying it to do country by country. Or European Union is doing a great job on that as well. Yeah. They are combining the system together. And for example, if there is like for a rare disease again, if you're in Belgium, you can go to Germany to get the cure.
But the process improvement approach, a sustainable process improvement approach to these systems, are you seeing a lot of that in your academic community, in your professional networks? Is this something that is
exactly
substantial presence?
Exactly. Now, every single process is including sustainability. As I mentioned when we were talking, we are not a part of European Union, but 70% of our exports are going to European Union. So they are forcing us to have all the regulations and the reports and downsizing the carbon emissions, decreasing the carbon emissions. So there's a huge investment now in those things, which the hospitals started to realize it, but it's not a regulatory option at the moment. It's just voluntarily done at the moment. Right. But because we are also good in healthcare tourism, it's a good greenwashing, I can say.
Marketing ploy.
Yeah, marketing policy. Right. So every step is actually helping us to understand what's going on. And now, especially, we are trying to become the leader with that conference, which we will have in November.
What's the conference?
Conference of Partnerships, COP.
Oh, the COP. Oh, yes. COP sorry. The climate conference.
Yes. So that's why now all sectors, each and every sector is trying to be a leader in that. So I'm sure that by the end of this year, we will see more improvement in this. But we are really good at it in the SMEs, or else they will be bankrupting.
Right. So in Turkey in particular, many industries are looking for these kinds of sustainability, not necessarily in healthcare, but perhaps increasingly in healthcare.
Yeah, well, quality was like that, though. I have met Joseph Duran in 2000 and what was it, 4, I guess? I'm not sure. Before he died, and it was his last conference, though. And what he said was, quality and production is done. We all know what we should be doing, but there are 2 sectors which are not touched yet. And he said it was healthcare and education. And it was 2008. And after 2008, the research just piled up, and you can see that people started to research and improve healthcare systems as well.
Right.
So it will be the same, probably, in sustainable.
For the process improvement in the industries,
Yeah.
right? Okay. I'm interested in the question. I mean, your work relies, I think, or perhaps I'm wrong, on a fair bit of clinical engagement, and perhaps also engagement and support from healthcare organizations, leadership within these organizations.
And the government.
And the government.
And the government, yeah.
And so, I mean, that exists. Many clinicians are interested in this work. Are they motivated to do this work, or
when I first started, it was hard to convince them that it would be their benefit. But then when we started showing them our researches and the results, and then I started having calls from the government to apply it to the group of hospitals of the different municipalities. For example, I transformed the laboratories of 11 hospitals which were connected with each other and make it a lean laboratory at the end. So it's not. It is a very. They are looking for it now, and they are aware of the improvement results. So yes, we do have a lot of people, a lot of clinicians who are dealing with this, and they learned about it at the moment.
Right. I mean, I guess one of the things that I'm trying to understand, I think, in this is, and you and I talked about this a little bit before, is whether or not sustainability is its own ambition within these improvements. So you're saying, I'm going to, the example would be, we're getting rid of this particular anesthetic gas, but it's not a process improvement. It's unto itself. It's an environmental agenda, and we're going to use process improvement techniques to get there. We're really bringing a process improvement lens to the operation of this clinic, and we're going to secure and measure environmental co-benefits from the reduced use of space, or at least that maybe it's not a net reduction, but it's certainly a per unit environmental cost. So that kind of question of I think the environmental benefits here are very much co-benefits of an agenda for process improvement, for efficiency and leaning. Is that correct?
Well, you're right. Firstly, they started to just decrease the carbon emission by transforming from fossil fuels to solar energy.
Right.
That was the easiest way to do it. So that's what they first do. And then, they say that we are segregating the waste already in healthcare, so there's nothing else to do, but that's not the topic. Then we are trying to show them that they are using a lot of plastic, a lot of excessive equipments which can be reused afterwards, or they can even share their equipment with other hospitals, etc. So they're not in that stage yet. They're just trying to reach the sustainability regulations faster, but not changing or transforming the process at the moment. I like you said the space, using the space more. I lost my English. Efficiency. Yeah. That's what we're trying to do as academics. We're trying to show them the way and help them to understand it. Well, everybody has their own specialty. I don't expect them to understand it.
Right.
We have to help them. Yeah.
But I mean, I actually, there's somebody who's listening in, who's a healthcare leader I had a conversation with earlier, and we were talking about the sustainability agenda just across local hospitals here in the Toronto area and the business case for this. And it strikes me that your work is incredibly helpful for articulating the business case for change, right, for sustainability. And much of it, though, like they wouldn't need to care about the environmental benefits to say, this is something we should try and invest in.
As I said, they're already exhausted with all the
right.
So we should make their life easier. And anything that they're doing, we should be drawing or designing the process in a way that they will just automatically be environmental friendly.
Right. But I guess, sorry, just to extend that then, but do you find that the clinicians that in our work, we find that sometimes you are advancing an agenda for improvement that is securing environmental benefits as a co-benefit. They're something that comes along with, but people are engaging with it because they're passionate about the environmental impact. And that's part of the motivator for involving otherwise really busy people and getting clinical leaders engaged or sometimes senior leaders engaged. Is that kind of question? We do have a
whatever you said, we had the same thing in quality applications.
Right.
So when first quality systems started, total quality management, quality, business excellence, Kaizen, Lean, Six Sigma, whatever you can think about, it's all the same process. I mean, it started the same. It's going on the same with sustainability, and it will result with success at the end because every resistance that we see at the moment, we saw it in the past with quality management. I'm a quality professor. I had my PhD on quality. So I can see that the processes that we're passing through is exactly the same. And it's making, when I tell this to the companies which I'm consulting, I tell them that don't be panic because you did this in quality applications in the ISO standards or whatever. And now just think at it as if it's like an ISO standard or a quality management system. But now the regulations are different. You have to just add those regulations into the system and it will be easier for you to cope up with.
Anita, do you want to go off mute and ask your question?
Hi, thanks very much for a very engaging lecture. Well, one of the most wasteful parts of the Canadian healthcare system is actually end-of-life care. So we, more than 50% of patients will actually die in hospital, often after undergoing painful and futile care to try and preserve or elongate the last days of life. My understanding was in other countries and perhaps in Turkey and in Europe that there were other mechanisms and sort of more ethical driven ways for patients if their condition is deemed to be futile. It wasn't always up to the families, which is often the case here. Have you worked on process pathways for something like that?
No, we are not allowed to decide on what the patient will have. They have to wait until the end of their life with pain or whatever. They're trying to, I don't know what they call it.
Advanced directives types of things?
Yeah, like they give them some drugs to make it...
medical assistance.
Medical assistance, yeah. But the family cannot decide on what to do. So I didn't work on that, though. It's not my research area.
Right.
Yeah.
And where have you found some of the most productive opportunities to move this forward in healthcare? I mean, I guess radiology is a particularly important space.
Chemotherapy units, radiology units, specifically radiology units, because we see that there are lots of idle machines waiting, MRI, CT scans, just because it was late there, or they didn't even realize that they had some time left and they were making the patient wait or were not giving the appointments. So we had, or mammography, for example, we had a case which the mammography equipment device or equipment, whatever you call it, was not working. And because it was a government hospital, they had to wait minimum 15 days for the service to come. So when you think that every day mammography was done to 30 patients every day, and if 8 out of 1 was cancer, then just think about how many women would be waiting for diagnosis for the 15 days. So it's very severe, and we found that very good improvement in it. And if it was cancer, they were just diagnosed in 2-3 days, not waiting much. So they were catching the patients immediately.
Right. So here's any other, looking for other questions, but I want to ask the difficult question from a sustainability perspective about efficiency and Jevons paradox. So the challenge of efficiency, which is that we reduce perhaps the unit cost per unit environmental impact, right? So to get a person through a pathway of detection of cancer to treatment, the per unit environmental impact is perhaps reduced, but maybe we're doing more of them. And maybe in healthcare, that's not a problem. The Jevons paradox is sort of, we all buy EVs, but we drive more because it's cheaper. Or we can heat our houses more efficiently with more efficient furnaces. So now we keep it warmer, or we have bigger houses, right? So those kinds of problems of efficiency as a pathway to reducing environmental harm has these kind of just inherent problems. And it does apply to healthcare as well, but you could argue that there's unmet need. And what we need to do is reduce, the sort of unit cost of delivering these services to address that unmet need. But there's a limit to that also, because at some point there is in healthcare, as in most industries, supplier-induced demand. We can overdo it. We can produce too much. We can give too much. There is such a thing as too much care and the harms of that. So I wonder if this kind of apologies to ask a management engineer these, but I'm sure that this is in your space, right? From a leadership perspective and a management perspective, how do you find that as a challenge? People are coming back and saying, you're not actually reducing the environmental impact of healthcare, you're improving efficiency, or that's really not a useful framing, or how do you think about that question?
Well, actually, a very good question, very hard one, by the way. But these are all the concerns that we're thinking about.
Right.
Though. I mean, we cannot find the most environmental system, though. It's impossible because whatever we do, it is causing carbon emission, emitting greenhouse gas emission. But we have to find a way which is minimizing it or finding the balance break-even point of it. Same thing in improving process. If you continue to spend more on improvement, and if the system cannot improve more, you will just be spending money for nonsense. So you have to find the balance. I do not believe in carbon net zero, by the way.
Yeah.
It's impossible because we need that. I mean, we are producing it and we cannot stop anything. We cannot go into the Stone Age and live in that way. Even in the Stone Age, we were producing carbon dioxide by burning wood. So we have to find the break-even point, which is, again, similar to Duran's cost of quality methodology. And so, yes, we are decreasing the cost by making more efficient systems. But at one point, it cannot be more efficient because the technology is not allowing you,
right,
or the environment is not allowing you, or the situation is not allowing you. Right. So so that's why we're using simulation software with different scenarios, some alternative scenarios, and then trying to sometimes put in both of the scenarios at the same time. So there are lots of different simulations that we're doing and trying to find a solution. But as I said, you cannot be 100% sustainable.
Yeah. Okay, well, I've possibly asked you enough tough questions. I'm looking around the room to see if anybody would like to add one. We've almost taken up our full allotment of time. Right. Well, seeing none, I want to thank you so much for this terrific talk, and thank you, those of you in the audience. We'll get a chance to chat more, and those of you online. Thank you for joining us. And
I would like to share my email address.
Oh, absolutely!
If you would like to make a collaboration together.
I do think there are very strong opportunities here around the supply chain emissions question. There's huge interest here in many healthcare systems around the procurement question, around mobilizing supply chain, about how you get industry to provide, clear answer. How do you ask very clear questions that can offer clear answers so that you're making a decision on buying a product on the basis of activities that they've taken, process improvements. that they've pursued. So I think that whole question, as well as, to be honest, I think that many health leaders, we here in this country, and I think in many countries are, we're back into sort of austerity. The healthcare system here, the hospital system here is really facing financial challenges more than they faced in decades previous. So in addition to the passion and the commitments and the expertise and the methods, they often are going to need to know that there's an ROI, that there's a business case to be made. And so some of this, I think this process improvement, it will not get us there, right, as you said, but it has this potential for a colleague, Penny Balaam, used to talk about triple word score of these kinds of accomplishments. You reduce carbon, you reduce cost, and you reduce burden on the workforce, right? So that's what you're talking about. So I think these things have tremendous potential for change, and I'm really delighted that you were able to share your knowledge and expertise with us. And I hope we get. I'm sure
it was an honor to be here at U of T.
Thank you.
Thank you very much.